Hello, madam, you can start. We have
Okay,
There is no change in your platform. Only the YouTube was showing some problem. We have given a new link, and they have
okay,
already. You can continue.
okay. Thank you. So we were discussing about the wear time. This article, which is published just 3 months back in November 21, about the uh, wear time of the appliances. Two different appliances, that is activator and twin lock. And it was interesting to know that there was no despite of the different designs, there was no significant difference between the monoblock and twin block appliances in the terms of compliance. Now, I would like to revise here about the all of you students. You have seen, you have read the Erickson stages of psychological development. Now, if you recollect, the fourth stage of psychological development, that is between the chronological year 7 to 11 years, 7 to 11 years, 4 years. So that is very good for, compliance point of view. But we have just now we read the reference about the reviews about the timing. Sorry, my connection is gone, or it is audible. Hello,
You are audible.
hello.
Hello, you
I'm
are audible.
audible. The screen is also, and the
Screen
screen
is
is also
also
not disturbed.
yeah. No, no. Audio, video, both is working.
Both is working. Okay. So we have seen that that stage is good from compliance point of view. So we have to have the compliance is better at that time. But 7 years is, that is early mixed dentition stage. We have seen that there is no skeletal changes because we are not yet into the pubertal growth spurt. So we have to find out which is the right way of targeting these children. If we are thinking about compliance is good, then we don't have to insist on 24-hour wear of the appliances, as this literature says. So we can have a part-time wear of appliances. Then we have to the, find a nice combination about the age and cooperation factor. Then when we this compliance is related with the comfort of the appliance, we cannot ask the children or we cannot expect from the children with a very good compliance with Frankel appliance if it is too much of single step advancement. FR2 has, we have seen the evidence that FR2 has shown a skeletal changes in the mandibular advancement. But at the same time, if somebody wants to take this evidence and do a single step advancement with FR2 appliance, naturally, if it is 7 to 8 millimeter of advancement, imagine the discomfort what the child is going to have with the mandibular posturing 7 to 10 millimeters, 7 to 8 millimeter forward with the lip pads and the bulky appliance. It is not that, comfortable. So the comfort of the appliance has to be uh, considered, and the bite. Single step advancement and two step advancement. Now imagine how it is interlinked. Now, the literature says that there is no significant difference in single step or two step. But yes, definitely, if you do a two step advancement, the comfort of the appliance will be there. And automatically, if the appliance is comfortable, the child will be more compliant. So, see how the factors are linked. So, age, patient related factors, the age and the cooperation, and then appliance related would be the comfort and the byte. Now, byte means two-step or single-step advancement. And the third important factor is the operator or we clinician. If we don't have enough knowledge or the skill of fabricating or even smartly using these components and selecting the appliance, then the failure will be there. So, see the three important factors in the myofunctional appliances. Success of myofunctional appliances are patient related, appliance related, and operator related. And I feel operator related are the most important factors, because you should know how to take out from the child the compliance, the cooperation, or you select the age of the patient, the timing of the treatment. We know that it is skeletal adaptability, the sutural adaptability is the maximum time we can achieve that. But that doesn't mean that you can ask a 12-year, 13-year-old boy to wear headgear, activator headgear, and expect the 100% cooperation. So you have to select. Now, when I said headgear, headgear is for the skeletal effects. Now, if we are looking for targeting the maxilla for sagittal restriction and vertical restriction, the vector of the headgear, so then you have to think about first about controlling the teeth, and then indirectly the occlusal plane, and whether you want the rotation of occlusal plane. So you can target with simpler appliances. So this is how it is. The knowledge and the skill of the operator is the first important thing which is important for selection of the appliances. So I think I have made it clear about which appliance is better than, it is, none of the appliances are better over the other. All appliances have good effects, they work satisfactorily. It is the operator is important in selecting the appliance, and of course the patient is also important from the compliance point of view. But then it is, compliance is how you select the, as I said, you can revise the Erikson stages of psychological development, and you will find that the fourth stage is good from the compliance point of view. But again, the craniofacial growth differences between the boys and girls are different. So that 2 years of this thing is very important from the uh, compliance point of view. So that completes my presentation. Thank you again for all of you for having for inviting me and participating as delegates in this webinar. Thank you so much. Thanks again.
Thank you, Dr. Gauri. And also, I'm sorry for the inconvenience caused to all the delegates and you for stopping the presentation for some time, but the problem was beyond our control. I now
No,
thank
that's
you for
okay. Thank
sparing
you
your.
so much.
Yes, madam, please. Don't leave
No, no,
the.
thank you so much. It's not
Yeah,
a
yeah.
big problem.
Yes,
The
yes, yes.
technology I mentioned in the
Thank you
beginning
for
only.
sparing your valuable time, that too during the active morning hours.
Thank you, ma'am, for sharing your
It
valuable
was a
knowledge with all
pleasure.
of us. I would now like to request Dr. Sneha Vagnare, ma'am, to present you a certificate as a token of appreciation from all of us.
Madam, I think instead of again, I will forward it to you by postal address. I know your postal address. Let us now continue before we have another lag in the internet
Yes, yes.
connectivity.
Thank you
Thank
so
you
much.
so much.
Thank you
Thank
so
you.
much. Okay, bye.
Bye. Dr. Toshniwal? Hello, Dr. Toshniwal, did you? Yes, Dr. Toshniwal.
Yes, madam, I am there.
You are there now. Okay. Welcome once again to the webinar from the Department of Orthodontics and the Institute, that is the Swargya Dadasaheb Karmik Dental College and Hospital, Vanadongri, Nagpur.
Good morning, sir. Now I would like to request Dr. Pankaj Akre, sir, professor from Department of Orthodontics and Dentofacial Orthopedics, to welcome our next speaker, Dr. Toshniwal, sir, to share his views on byte registration for various myofunctional appliances.
Dr. Toshniwal, a small request. Can you start your camera?
Yes, madam, I will start. Just 1 minute, madam.
Good morning, sir.
Yes, good morning. Just 1 minute, give me. Yes, good morning.
Good morning, sir.
Should I start my presentation?
So let me just introduce to you.
Okay, thank you so much.
A very good morning to one and all. I, Dr. Pankaj Akre from Swargya Dadasaheb Karmik Smriti Dental College and Hospital, Nagpur, would like to invite all our well-known speaker for today, Dr. Toshniwal, sir. Dr. Toshniwal, sir, has completed his Masters in Orthodontics from Government Dental College and Hospital, Nagpur in the year 1993. Presently, he is working as Professor in and ex-Dean Dental Faculty at Pravra Institute of Medical Sciences, LONI, Maharashtra. He is the active teacher, PG teacher since last 20 years and a PhD teacher for the last 5 years. He has also completed his Masters in Public Health. He has delivered several guest lectures and also keynote addresses in almost all orthodontic and dental conferences and PG conventions in the last 15 years. He has won several awards from Indian Orthodontic Society for clinical innovations in functional orthopedics, best research and clinical papers. He has almost more than 100 publications to his credit at national and international journals. Presently, he is working on an editorial board of several national and international index journals. He is a section editor of Growth and Development in the Journal of Indian Orthodontic Society. He has organized almost 17 national symposium, including recent iOS PG and exam orientation program. He has worked as a national coordinator for almost all IDA and iOS conferences in last 2 decades. And he has drafted the syllabus for bioethics for Dental Council of India. His special area of interest are functional orthopedics and evidence-based orthodontics. He is an active member of prestigious national and international organizations like IDA, iOS, WFO, EOS, and AAO. He has received several honors and awards for faculty development programs at various health universities. So I would like to invite Dr. Toshniwal, sir, for today's CD program. Sir, I will hand over to you.
Thank you so much. At the outset, I would like to thank the organizing committee, Dr. Rashmi Madam, yourself, and all faculty members, including the patrons of Kalmeg Institute, for giving me this opportunity to be in front of all of you. And it was a nice collection of the speakers from the highest institute in the country, that is GDC Orthodontic Nagpur alumni. And I must congratulate Dr. Vichare Madam for explaining the selection of the appliance in a very nice way, so that the things will be quite thorough into the mind of postgraduate student. So the topic today allotted to me was byte registration. And now may I request the host to allow me for a screen sharing? Yes, thank you so much. Am I audible and my screen is visible?
Yes,
Hello?
yes, yes.
Yes. So blessings to all of you from the holy place of Shirdi Sai Baba. My university is just near to it. Why I put the picture while starting the lecture on functional jaw orthopedics? Before that, this person has spent his whole life on two principles, that is Shraddha and Saburi. So if you have a faith and patience in functional jaw orthopedic, definitely they will work. So what is more needed is the patience in younger generation. This presentation has been devoted to my teacher who led my path in orthodontics, Dr. Sable, respected Deshkar sir, who made my concept clear at undergraduate layer, and Madam Hazare, who had led my path in the postgraduate life and who have designed my life. This presentation comes to you from Pravara Institute of Medical Science, a deemed to be university, which gives the lessons to each and every student on problem-based learning and evidence-based solution to the problems in orthodontics. Then this university also promotes the cost-effective orthodontic journeys for those who are under rural poor with multiple challenges and solutions. So, coming to my today's topic, the most important what I feel is that the first impression is the last impression. The M.D.S examination starts with functional jaw orthopedic, and the exercise given to all of you will be the recording of a construction bite for functional jaw orthopedics. So, the concept of the construction bite should be very clear, and it is not the mechanical job, it's a biological approach. All of you know that the form determines the function, and we are all are craniofacial growth specialists. We accept the challenges in the biology, we find out the solution. We may use functional jaw orthopedics, we may use dentofacial orthopedics, or we may combine both of them together to solve the problems of the craniofacial growth. When you are dealing with the growth modulation, before you actually understand the principles of construction bite, you should revise yourself with the craniofacial growth, its timetable, and the principles to follow. There is lot of debate in the literature regarding one phase versus two phase orthopedic treatment, and the literature nowadays, the evidence concludes that the right time is more important, and it comes to the circumpivotal growth spurt. The first principle of growth modulation with these appliances says that if you start the growth modulation too early, it takes long way to go. So right start is more important so that the treatment becomes short and sweet. The second principle says, which we have learned, that the growth stops in different dimensions at different rate, and the transverse problems need their attention first as compared to anteroposterior and vertical. And the most important is that the girls matures much more earlier than the boys. So the third principle says that a lady's first approach in craniofacial growth modulation must be 2 to 3 years ahead than the boy. So the functional jaw orthopedic has made a great progress. At first, it was an initial timid step, but later it has become an autonomous branch of an orthodontics that has attained its scientific level at an highest site. In the slide, you can see that up there are removable appliances, which are the traditional approach, while at the bottom there are fixed functional appliances with expansion screw for assessing the or correcting the three dimensions at one time. But the most important for all of you to remember is that when you are dealing with craniofacial complex of a growing individual, it's a highly biological discipline, and you are a first biologist and then a clinician. And the most important traveling companion for the functional jaw orthopedics is a growth. If there is no growth, no functional jaw orthopedics. So before we actually proceed to the byte registration concept, we should know the evolution of the appliances and evolution in the byte registration concept. The first documented incidence for orthopedics in stomatognaathic apparatus goes way back 1741. The science is old. All of we have learned about Catalan's functional appliance, which was made up initially of a metal used to correct an anterior crossbite with functional forces. The first concept of jumping the byte has came from Normal Kingsley, where he had used anterior inclined plane for correcting the class 2 molar relationship, and he was being termed as a father of functional jaw orthopedics. This was a birth of functional jaw orthopedics. Later, the history reveals that there was a simultaneous discovery of an activator and a monoblock. Two different group of people working at two different places came to the same conclusion. Dr. Perry Robin was working on Robin syndrome and termed this vulcanite appliance as a monoblock, while Anderson has given the class 2 corrector for her daughter who was supposed to go for long vacation, and once he saw the correction, he named it as a biomechanic working retainer. The first documented evidence for the fixed functional appliances was the Herb's appliance, the invention of the Herb's appliance, a rigid one, 1909 by Emils Herbs. Then come the oral screen by Newell almost 4 years later, 1912, which the main objective is to correct the mouth breathing. Alfred P. Roger was the first person who termed muscles as a living orthodontic appliances and said that if you train the muscle properly with a proper appliance, the muscle will correct the malocclusion. It was William Balther who invented the bionator, said that it's a tongue trainer and will improve the volume of the orofacial capsular matrices. It was a Rolf Frankel, German demographic, who said that muscle can be used as an anchorage source and termed his appliance as a Frankel after his name with a concept of oral gymnastics. But the main milestone started in functional jaw orthopedic on 7 September 1977 with the invention of the Clark's twin block.
Yes, Dr. Toshniwal. Sorry for the interruption. All the delegates also. We can start.
Okay, madam. Am I audible? The screen is visible?
Yes, both you are audible as well as the screen is visible now.
So we have started with the first slide, that is the how to define about the construction byte. It's an intermaxillary three-dimensional wax record which is used to relate the mandible to the maxilla in all the planes of space, that is transverse, sagittal, and vertical. The next question is why byte registration is necessary? What are the purpose does it serve? The purpose of byte registration is based on two principles, force application and force elimination. It relocates the jaw in the direction of the treatment objective, and this creates the artificial functional forces which are transformed and transferred by the appliance to the jaws and teeth. There is a difference between these two words, transformed and transferred. Let us see what exactly it means. The next question is that what do you mean by degree of activation? The construction byte determines the degree of activation of the appliance, and most of the failure in the appliance and the complication is because of the wrong byte registration or not following the byte registration protocol. The mode of force application, the magnitude of the force generated, and the direction of the force which has been applied on the stomatognathic system depends upon the three-dimensional dislocation of the lower jaw, that is mandible, which will be determined by the construction byte. What kind of the force functional appliance they generate? The functional appliances, as the name says, that the forces are functional, that is muscular in nature, but their activation is artificial, and that activation is generated through the construction bite. The various factors which affect the construction bite. There are mainly the 4 factors which affect the record of the construction bite. The first one is the type of malocclusion, the morphologic growth pattern, the developmental stage, sex, and age of the patient, and the type of the functional appliance which you have selected. Now, the first factor, type of malocclusion present. By this time, before you record the construction bite, it is clear in your mind that you have calculated the skeletal discrepancy, dental discrepancy, you have identified the type of malocclusion, and you have made the differential diagnosis of overjet and overbite. Here, the student mainly make the mistake, they feel that increase in the overjet is the area of dislocation. It is not like that. The second one, the most common thing which you need to understand is that whether there is a functional retrusion of lower jaw versus true retrognathism. That is what is we do with the functional examination and path of closure, and we find out whether it is a true class 2 or a functional class 2. The functional appliances are more preferred for functional class 2 as it corrects the functional retrusion. So it needs an advancement depending upon the obstruction which has been created on the dentition to go for functional retrusion. Then, of course, the morphogenetic growth pattern, one used to use the functional appliances were carefully with a high grower as compared to an horizontal grower, which are more favored for functional jaw orthopedics. Then, of course, starting at correct time for a correct sex is more important, as we know that the timing, the 4th dimension. Here, I would like to recommend the postgraduate student to read the book on growth modification, what works, what not, and why, because the correct start is more important. And of course, the 4th factor is the type of functional appliance you are going to construct, either removable or fixed. And in removable, you have a choice from monoblock to the twin block. The next question, what is mostly asked is, what is Dr. Swa's 3-point concept in construction bite? This is a concept given by Dr. Martin Swas way back in 66. He said that your byte registration corrects the 3 dimensions. Of course, these are transverse, anteroposterior, and vertical. And this extent of correction in all the dimension depends upon facial asymmetry or versus symmetry, the type of malocclusion, and the moment in the functional jaw orthopedics accordingly. The next question is that what do you mean by pre-functional therapy and when and why it is indicated? Most of the time in exam we get the case directly which has not been completed with a pre-functional objective. So here you need to answer that you have to achieve certain pre-functional objective before going for construction bite. Let it be an anterior cross bite. Let it be a very narrow upper jaw. All of we know the foot and shoe mechanism discussed by McNamara, and almost 75% of the class 2 had the transverse maxillary component. So you have to make your shoe wide before you insert a feet inside, and that is foot and shoe. The next important is the assessment of the diagnostic record before proceeding to the construction bite. So your diagnostic preparation should be very thorough and clear. We start with functional analysis, we start with the VTO, we start with the cephalometric and the study model analysis, and that determine exactly how you're going to record the construction bite. The concept of VTO, whether it is clinical or radiographic, it has been very nicely discussed on the 2 books written by Dr. Roberts Ricketts, Volume 1 and Volume 2 on VTO, published by Rocky Mountain Orthodontics. The clinical VTO says that what you see is what you get. So you need to motivate the patient. You ask the patient to bring the lower jaw forward into incisor edge to edge. He can see the improvement in his facial profile, and that acts as an instant correction with 100% positive VTO, a motivational aid getting in compliance from the removable appliance. Many of the time, your VTO is only 50% positive. If you ask the patient to bring the lower jaw forward, the face improves by 50%. That means there is some defect in the counterpart of the jaw, that is the maxilla. So here you need a combination approach. And the third is, many of the time, even asking the patient to forward, it looks like an bimaxillary protrusion or the face is not looking good. That means the case is not suitable for functional jaw orthopedics, and you should does not select the patient who has got a negative VTO. The important parameters to be learned from model analysis before proceeding to the construction byte, because ultimately your planning of construction byte depends upon the correction of molar relationship, determination of the depth of the curve of P, coincidence of the upper and lower midline, the well-aligned arches with optimum width of the arches. The upper arch should be wide enough to accommodate the lower jaw. So all these things, the mathematical calculations and the predicted position should be ready before you proceed for construction byte. The important clues in functional analysis which you should keep ready before recording the construction byte is your assessment of freeway space. Does there are any occlusal interferences which are deviating the lower path of lower jaw? Whether your TMJ assessment is proper, and whether path of closure and respiration is proper. So all which we have learned in diagnosis with functional analysis. The important parameters to be looked into the cephalometric analysis is the morphological characteristics of the jaw rotations, the inclination of upper and lower incisor, the relationship of upper and lower jaw with each other, and of course the direction of the growth. So performing an optimum lateral cephalometric analysis is mandatory before proceeding to the construction byte. All of you should be very familiar with the Clark cephalometric analysis if you are going to select a twin block, and most of the time the student, they don't do this and they lose the mark. So you should know what is the Ricketts triangle and facial rectangle with the key angles, that is cranial base angle, facious axis angle, and mandibular plane angle. Now, the byte registration protocol. It depends upon the type of malocclusion which you are correcting, whether you are class 2 or class 3. For example, in class 2, demand the anterior positioning of the mandible. Sometimes it may be a symmetrical advancement, sometimes it may be asymmetrical, and sometimes it may be a pathological construction byte. Let us see what exactly is that. In class 3, it's the reverse, that is a posterior positioning of the lower jaw. The symmetrical byte registration concept for angles class 2 division 1 determines that there is a full cusp class 2 bilaterally, molar and canine, where you are advancing the lower jaw forward without changing the midline, as there is no midline discrepancy, and that is known as symmetrical byte registration. Vice versa, in symmetrical byte registration for class 3, you are forcefully retruding the lower jaw back without changing the midline and correcting the malocclusion with the construction byte. When the question of asymmetrical byte registration comes, where there is a subdivision malocclusion, or at one side you have got full class 2 and another side it's an end-on. So here the midlines are also not matching with each other because of some jaw deviation, and here you need to correct the transfer as well as anteroposterior dimension along with vertical to get a symmetry in the dental arch, and that is known as asymmetrical byte registration, which you sometimes get during the examination. How one can plan for construction byte? Always remember that the construction byte should be always in the patient's mouth and not on the study model. Because when you do it actually on the patient, it gives a good fit of the appliance, it gives the comfort, and there is no stress on the teeth as compared to the fitting on the models. The general rules to be followed before taking the construction byte, I always will discuss about class 2, the reverse will be for class 3. The first principle is that, are you advancing the lower jaw in single step versus stepwise advancement? If the sagittal discrepancy is too large, then the anterior positioning of the lower jaw is recommended to be stepwise for the physiologic comfort and good result, and it moves the lower jaw in the three planes of the space stepwise. Then the pre-functional incisal correction, as already I have determined that we have completed, that is, if there is any severe pronation of the maxillary incisor, it should be corrected before you record the construction bite. More you go for a horizontal advancement of the lower jaw, that is 7 to 8 mm. For the comfort of physiology, you have to keep the vertical opening very minimum mild to moderate, just 2 to 4 millimeter. So that is the third objective, is that more you move the lower jaw horizontally, less should be an vertical opening. If you are going for vertical correction, that is, if you are opening the bite too much vertically, that is 3 to 5 mm, then you should not move the lower jaw much more ahead. So vice versa, vertical correction demands vertical opening without horizontal displacement. Then the transverse discrepancy has to be identified before recording a construction bite. Many of the time, the midline shift may be skeletal in nature or may be dental in nature. Always in functional jaw orthopedic construction bite, skeletal midline should be corrected as needed, and the dental midline should not be compensated by moving the jaw in a wrong direction so as to have the iatrogenic malocclusion. The principles of Byte Registration. There are three principles, that is transverse posturing of the mandible, horizontal posturing of mandible, and vertical opening of the mandible. Let us see the transverse posturing of the lower jaw. In symmetrical skeletal corrections, there is no component known as a transverse discrepancy, but when a question comes about asymmetry, definitely a skeletal asymmetry has to be corrected with the construction bite so that the midlines, they match with each other after the construction bite. But if it is a dental midline shift, the dental midline discrepancy should not be compensated into the construction bite. This is what is most importantly you should remember. When there is no transverse component, no midlines are matching with each other without any skeletal deviation, that means there is no transverse component into the construction bite. For that, you need to evaluate the postural changes of the lower jaw from rest to occlusion in transverse plane. Sometimes it leads to functional crossbite. Sometimes it may go to the pseudo crossbite like in class 3, or sometimes it may go to lateral occlusion. So that is functional interferences which need to be corrected in construction bite. So it's a good prognosis for functional therapy. But when you see that there is disturbances in the dental midline because of the true close bite and the laterognathism, then these are not the good cases for functional appliance. So true asymmetrical facial skeleton should not be corrected with the functional jaw orthopedics. Profit has discussed nicely about the prognostic consideration of functional jaw orthopedics in his recent text and concluded about the different dimensions, how they respond to the treatment, and what will be the good to fair prognosis. Horizontal posturing of the mandible depends upon the four possibilities. That is, whether you are changing, there is no change in the sagittal dimension, it is mainly done for the class 2 with maxillary prognathism, or skeletal class 1 malocclusion with class 2 dental symptoms. A symmetrical mandibular advancement is generally done in angles class 2 division 1, which is skeletal in nature. Asymmetrical bite recording should be done in the subdivision type of malocclusion, either on the right and left side. While in class 3 also we have to follow the same principle for symmetrical as well as asymmetrical bite registration. The vertical opening is the most important thing because that determines the homeostasis and adaptation of functional phenomena. So one need to understand the morphogenetic growth pattern and the type of the appliance and the age and sex of an individual. In class 2 due to most of the time, if the pre-functional orthopedics have not been performed, then byte registration is usually done in edge-to-edge manner with central incisals retrocline, and that demands the use of jet spring from inside and correction of functional cross bite. In class 2 division 1, symmetrical byte advancement, interincisal opening, then horizontal advancement, all this determination has to be depend upon the differential diagnosis of overjet and overbite. Many of the time we go for edge-to-edge byte registration, and that prevents the lateral tongue spread and good enough for controlling the tongue function. In class 3, especially in pseudo class 3 malocclusion, we go for forceful byte retrusion with interincisal opening of 1.5 to 3 mm, and symmetrical as well as asymmetry depends upon the subdivision of the case. How one should assess for the postural rest position, I will not go because it is a diagnostic part, but one has to measure the intraoral vacuum, the degree of wakefulness, head and body posture, that is NHP, and everything so as to go for the correct assessment of freeway space. What do you mean by no tooth interference zone? That is the most commonly question asked. The construction bite should be open wide enough so that the mandible is out of range of any tooth guidance, and the resultant retrusive effect on the condyle and the path of closure is eliminated. So you need to answer that your bite is in no tooth interference zone, and these are few of the followingly discussed factors which tells you that whether it is there or not. The technique for byte registration. The examiner will ask you which of the 10 steps you have followed in byte registration and what is role of 10 in byte registration. So let us climb stepwise to have the accurate byte and accurate concept. It is 10-step byte registration protocol. You should remember it very thoroughly, and you should not meet any one of the steps so that to go for the fair to poor prognosis. The first step is positioning the patient correctly into the correctly designed dental chair. The patient positioning is very important. The patient should be vertical enough. The chair should be arranged properly. The patient should be made to sit upright. He should be relaxed. He should be free from tension. You should talk with a soft skills with the patient that he will be operated for the wax bite and which may not harm him. So that is the communication skill and patient positioning step number 1. Step number 2 is that you yourself first to confirm the VTO by asking the patient to move the lower jaw forward. And once you are confirmed that VTO is positive, then you have to show the same to the patient through the mirror that this is how you are going to look, and please cooperate with for recording so that you will have the correct face at the end. So step 2 will be headed as VTO confirmation, of course clinical VTO confirmation. Step 3, the most important step in construction, receptive engram. Examiner will ask you, what do you mean by exteroceptive engram? You should able to tell that when you request the patient to bring the lower jaw forward, show him on the mirror, and you ask him to practice it repeatedly, a time will come that the patient will move the lower jaw very correctly with your verbal instruction, and that sets the physiologic response in the patient's somatognatic system, which will start working on it. So that is step 3, setting up an exteroreceptive engram. The step 4 is the selection of the byte registration material, that is modeling wax. Here, all of we know the ideal requirements of byte registration material, and modeling wax made from a proper company, a renowned company, gives you a feel of that. And here, the most commonest mistake the student they do is that they take too much hot water or too much cold water. The correct consistency of softening this modeling wax is more important, and always one full sheet should be used, and the sheet after rolling it into the hot water should have a diameter of 1 centimeter. that is 2 to 3 millimeter more than the planned byte registration in vertical direction. So step 4 is selection and manipulation of byte registration material. The step 5, manipulation of your wax roll. You can correctly see in the diagram that you have to place your wax roll on the lower model, shape it according to the shape of the dental arch. Always take the the wax roll little bit inside to the lower teeth buccally as well as anteriorly, and have a V notch at the anterior region with your finger so that you can match the midline correctly if you are asking the patient to close while recording the bite. The most commonest mistake what the student they do here is that the height of the softened wax, it should be sufficient enough, wide enough, 2 to 4 millimeter than the desired vertical dimension, because ultimately the patient has to compress on it with the occlusal pressure, and you should get a correct indentation of upper and lower occlusal table on the good consistency of the wax. So that is manipulation of wax roll. Then step 6 is that properly transfer of that softened wax rim inside the patient mouth and relocating it and adapting it onto the lower arch and fitting it onto the lower arch. That is wax rim transfer. Step 7 is mandibular advancement. As you have set up the exteroreceptive engram, just ask the patient to move the lower jaw forward as has been practiced by him. He moves the lower jaw forward as determined by you and as practice, and once we are satisfied with that, we ask the patient to close and stop, and we record the correct construction bite. If the patient doesn't respond with the properly planned advancement, please don't go ahead. Repeat as the whole procedure till 7. And here, most of the time, too much soft wax, especially in summer season, during exam season in May and June, especially orange city having 48-47 degree temperature, already the wax is so soft, you hardly need any hot water so that you can use it properly. Then the trimming of the wax bite. Once you remove the wax bite from the mouth, you should keep it into the cold water. Then excess wax which has come out from the occlusal surfaces has to be trimmed properly with a scissor and knife. And here you should see that the wax has become hard. Don't do it on a soft wax. Have the proper chilling of the wax rim and then do it. That is trimming of wax bite. Then the step 9 is that conformative approach. The trim wax bite has to be kept on the cast, and you have to check and mark on the cast that how much vertical opening you have made and how much horizontal opening you have made, because examiner will always like to see it on the cast. They will like to measure it and they will ask the question pertaining to the horizontal and vertical opening. So please confirm it on the model. Don't confirm and press it on the model. Please do it intraorally too. And the last step is reconformative approach, that whatever the bite which was fitting correctly on the cast, which has been previously recorded on the mouth, has to be again replaced into the mouth, and ask the patient to move the lower jaw a little bit slightly forward as determined previously, and not to press him too much, and confirm that it is fitting properly, and that is the correct way of registration of the construction bite. Now, this registration of construction bite, it varies from functional appliances which you have selected. It varies from activator to bionator to the Frankel to the twin block. Let us see what are these variations and what the author feel about it. If you start reading a textbook on management of class 2 written by John Bennett recently in last decade, he has concluded that nothing like an monoblock. The activator is a sole class 2 corrector, and if you get a proper compliance with that, nothing works like this. But compliance is an issue with activator. So for an activator or a monoblock, he recommended that mandible should be advanced by 4 to 5 mm and bite should not be open more than 3 mm, so that to have the comfortable wearing of an activator inside the patient mouth. Here, the three concepts of the bite registration or the three schools of thought one should remember. The first school of thought is given by Anderson Hopal, which based on the horizontal activator, that is the height of the construction byte is quite low as compared to the horizontal advancement. So that is known as H activator, where the low construction byte has been taken with a maximum mandibular forward positioning. Vice versa, in V activator, the school of thought is a Harvard outside school of thought, where the construction byte is dependent upon the high construction with the increase in the vertical height more than 4 to 6 millimeter or beyond this freeway space. This depends upon the viscoelastic property of the tissues, emptying of the vessel, stretching of the fibers, and so on. That is the second school of thought. And the same procedure has been repeated for the class 3 malocclusion. Here, instead of taking the lower jaw forward, you are taking the lower jaw backward, especially in pseudo class 3. When you are recording a byte for bionator, Balther has recommended that it should be an edge-to-edge relationship, which is at least at the lateral incisor, which provides the maximum functional space for the tongue to get corrected and retroposition. So the bionator should be recorded in edge-to-edge manner. The forward positioning, if it is large, the vertical should be kept minimum. In reverse bionator, like in class 3, you are going to retrode and make the lower jaw in edge-to-edge. Then when you are recording and construction byte, again, Dr. Rolf in Frankel philosophy has recommended the incisal edge-to-edge relationship with vertical opening sufficient enough just to crossover of the wires to pass through, and vertical opening has to be kept very minimum. So this is a construction byte example for class 2 and class 3 with edge-to-edge byte, and these are the different components of the appliance. Coming to the byte registration protocol, which Dr. William Clark has taught us during 2008, the most iconic conference of iOS held in Orange City, where he concluded that in horizontal activation demands a single step activation, while if you are going for progressive advancement, go it more when the overjet is too much, more than 10 millimeter, and functional activation with the twin block should not exceed 70% of the protrusive path. So that is what the William Clark in his personal meet at Nagpur has concluded in his slide. The byte registration protocol for the twin block appliance depends upon the comfort zone. The next question which the examiner will ask you, what do you mean by comfort zone? It is nothing but the intergingival height, which is measured from gingival margin of upper to that of the lower, and to determine what is exactly you mean by a comfort zone. Dr. William Clark has recommended in his textbook the use of project byte gauge, the most appropriate tool to advance the lower jaw forward and to open the byte vertically. Every time you will get a stop clock or you will get a clamp to stop with a byte fork, and you will get a correct byte registration. So that is the use of project byte. The Clark concept of byte registration. It is a accuracy of the project byte gives you more accurate sagittal activation, and vertical opening depends upon that. Now let us have a mode of action. How a single piece appliance like an activator bionator differs with two piece appliance like a twin block. The single piece appliance doesn't permit muscle shortening. It goes for isometric contraction of the muscles, and they are of higher in force magnitude, while the twin block permits the muscle shortening. The contractions are isotonic in nature, and the magnitude of the force is lesser in nature. Then the single block appliances has got a long lasting tonic effect, and they impede the movements of the jaw, while the twin block doesn't impede. Twin block permits more wearing time and more effectiveness as compared to the single block. Now, when you are doing the bright registration within the limit of freeway space, this is generally done to get the proper reflex contraction of the muscle during mastication. And this is to be done within the limit of freeway space just to activate the elevator muscles of mastication and to deliver the proper forces. This kind of bite registration requires the muscle force during swallowing and biting, which you can videographically can see into this slide, that we are using the forces of swallowing and biting in nature. All of we know about the glass knife reflex. I will not revise here in detail that when the teeth engage the applying, the stretch reflex is activated, which elicits the reflex muscle activity in the muscle tendon, that is Golgi tendon, and the glass knife reflex, which is usually asked in the examination. Then what is a bite registration beyond the freeway space? This is how it activates vertically, generates the myotatic reflex in the muscle of mastication, and it increases the biting forces. Now, the main force for generation is determined by vertical active tension in the stretch muscles during the vertical opening of the jaws. And when you open it beyond the freeway space, this myotatic reflex acts vertically more to correct the deep bite as compared to an horizontal activation. So the contractions are isometric in nature, and this is what I was discussing about the class knife reflex. You should know about Golgi tendon organs and the class knife reflex in construction bite protocol VIVA. The significance of knowing the class knife reflex is to protect the overload by preventing and damaging of the muscle forces, stretching them too much. Then extremely beyond the freeway set, that is vertical opening as recommended by Harvard and Woodside. Mainly it is done for vertical correction, but patient is not that much comfortable with so much of vertical opening. That's why it has not become so much popular. But when you do it, the process is known as a bioelastic process. And the concept behind this is a viscoelastic properties of the muscles that has been nicely discussed in Graeber-Rakosy and Graeber-Petrovic and Graeber-Newman textbook. The next question is a physiologic protrusion limit of the mandible. One should know what is exactly the physiologic protrusion limit of the mandible during bite registration. That the mandible in a position should be protruded in a bite approximately. The most important is 3 mm distal to its most protrusive position when the patient is active and achieve that, and this is what is known as the protrusive limit. So always you should record the bite registration 3 mm distal to the most protrusive position of the lower jaw. Grood in 1951 has said that the appliances generally they are squeezed between the jaws, they act like a spin, and he said that viscoelastic property of the muscle and stretching of the soft tissue, they generate potential energy, and that is with the correct bite recording. So two universal statements of the Grood you must know, that the first one is that the interocclusal distance varies not only among the individual but with the same individual from time to time. So that is what is the first statement. And the second is postural rest position of the patient depends upon head and body posture, the degree of wakefulness and the sleep and intraoral vacuum. So your postural rest position may vary from time to time. The next question, what they ask is, what is pterygoid response? You say that when you will get it and how you will check it. With the functional jaw, orthopedic Petrovic has concluded that you activate the heads of the lateral pterygoid muscles, which play an important decisive role. And mostly when we ask the patient that the superior head of the lateral pterygoid muscle, once they get activated and adapted, even if you remove the appliance from the patient mouth, the patient will keep the lower jaw position in the same way which you have desired with the construction bite, and that is what is known as getting up and pterygoid response, as the heads of the pterygoid muscles have been set for the new desired position. So all of you should know about the pterygoid response. Then the three concepts of bite registration, three schools of thought. I will just summarize the first school of thought given by Anderson, Hopal, McNamara, and Petrovic revision, that you have to have more horizontal with less vertical, and this is mainly done for loose fitting appliances, and getting a more horizontal correction with muscle contraction, which are myotatic reflex activity. because this generate the kinetic energy, and the forces are intermittent in nature, and this is how the functional appliance with low construction byte, they work on kinetic energy. Vice versa, the second concept given by Harvard, Woodside, and Selmer Olson, it depends upon the vertical opening beyond the freeway space too much. And here the forces are generated work on the potential energy. And this is a difference between the school of thought that once you activate more horizontally, you generate kinetic energy. Once you activate more vertically, you generate the potential energy. And in third approach, which is a combination of horizontal with the vertical, and given by the new author, says that when you employ this kinetic plus potential energy together, you get a more desired response and more active corrections into the muscles of mastication. So what is a force analysis in functional therapy? The force analysis in the functional therapy activate the muscles. The activation of the muscles and the forces created may be static, may be dynamic, may be rhythmic in nature. The static forces are permanent and they vary in magnitude and direction. They do not appear simultaneously with the movements of the jaw, and these forces are the forces of gravity, posture, elasticity of soft tissue, and the muscles in this category. While the dynamic forces, they are interrupted in nature and they are generally appear simultaneously with the movements of head and body. The frequency of these forces also depends upon the design of appliance, and the frequency also depends upon the construction byte. So always swallowing produces dynamic force. They are interrupted in nature and quite higher in magnitude as compared to the static forces. And what is the combination is the rhythmic forces. When you are using the combination concept intermittent plus interrupted, what you get is the rhythmic force synchronized with the bleeding, which transmit rhythmic vibration to the maxilla, and removal of the appliance from the mouth intercept with these forces. So that is known as rhythmic forces. So in conclusion, I would like to show you some of the innovation which we have carried out in our department and we have patented for it. So the first innovation which we do, it is on planner's direct tract. So this is public, it has been published. So please go through the photographs. So in conclusion, what sector of orthognathodontics is most sensitive to the aspect of preventing dysgnathia, if not the functional orthopedics? And Department of an Orthodontics for Innovation of Planners Direct Tract had received the Best Clinical Paper Award in 43rd IOC at Mumbai. Department has also patented and innovated the design of the fixed twin block in personal presence of Dr. William Clark in 42nd IOC Nagpur. The department has received the Best Clinical Paper Award for designing this appliance. So certainly genetic engineering is not the immediate future. Functional orthopedic is the only biological approach for preventing and correcting dysgnathia. When you talk about the pranayama, when you integrate the functional jaw orthopedic with an exercises and diet, doing the routine pranayama and anulom vilom pranayama along with functional jaw orthopedics gives you an optimum lip silk and rapid response, and this avoids invasive and costly mechanical therapy and complicated surgical therapy in a later life adulthood. So please integrate orofacial gymnastic with functional jaw orthopedics. We have innovated several appliances in our department, which like a modified 3D fixed twin block are appliances. We have received the awards from ICMR for this innovation. So certainly this therapy being cost effective will reduce the healthcare expenditure both for public and private sector. We have also worked on wind instrument and voice gym along with functional jaw orthopedics. And when we have asked the patient to perform certain exercises like singing of Gayatri Mantra, singing of the Ram Raksha, playing of the flute, which has given us the best possible output in craniofacial musculature tested electromyographically. So the orthodontist of the future must take into consideration, and it should become involved at an earlier age with simple functional jaw adjuncts than to prevent an interstep developing malocclusion, which demand excessive mechanotherapy at a later date. So use of wind instrument and voice gym is a new concept in integrated functional jaw orthopedics. So in conclusion, follow the genius leaders in functional jaw orthopedics, learn from them. Your path is there, and every day for us is to learn, unlearn, and relearn. And this slide I have kept purposefully in front of you. It's a memory of mine of 2008 conference where 3 generations of functional orthodontists have been felicitated by the organizing team for the best innovation. Thank you so much.
Thank you, Dr. Toshniwal, for such an enlightening and detailed presentation. I'm sure all the PGs must be relieved to have everything in a summary without reading the long texts. Thank you very much.
Thank you, madam, for giving us an opportunity. Thank you,
And
everyone,
I,
for.
yes,
Should I
sir.
log?
Yes,
Should,
continue.
should I log out, madam?
No, sir. I just want to thank you once again, and I'm sorry for the inconvenience caused for and taking your time. But the internet connectivity of college platform was good. YouTube had some problems, so it was beyond our control. Thank you for bearing with us and sparing
Thank,
your
thank,
valuable time. Thank you so much.
thank you so much. It's a pleasure of mine, madam.
Thank you so much.
Wishing you all the best of health in the coming days.
Yes,
Yes,
Thank you.
and
Dr.
looking
Dr.
forward to
Toshniwal,
practical,
I'm really privileged to hear the. I was in a meeting, but I was really privileged, and it's still what you say now, connoisseur to the eyes as well as ears and brain, listening to you
Thank
and
you,
your master.
Sunita. We have enjoyed our days in our PG life, and we
Yes, yes,
miss
true.
you too much.
Yeah, sure. We miss you too also.
Chalo, I am ready to listen to you now, Sunita.
Yes, let's say.
Okay. Thank you
Um,
so much.
uh, Madam Rashmi, madam, please can you
yes,
allow?
yes, yes. Yeah.
No,
Uh, Good morning, Sunita, and
I'm
thank you
not
and
able to
welcome
join
for
my video cam.
joining and sparing your time in spite of such a busy schedule. So, without taking much of your time, we should start with your presentation. I know you are too busy today.
I need to. Actually, there were too many things today. Okay. Can you allow me to screen share?
The IT person will help you in logging in. Just he will give you the
Yes, screen
instructions.
share.
Login करना है.
Hello. Hello.
Is my screen visible?
No. He's giving you the instruction to join on the college platform. Madam, please
One.
follow it.
मैडम आपको वहाँ पे दिख रहा है एक शेयर योर स्क्रीन करके एक लोगो आया होगा नीचे में
नीचे में ये हाँ एक ये लोगो है हाँ लेट्स सेट अप योर पेन नहीं ये नहीं है कहाँ पर है I technical support even I need it so I'm just taking technical support हाँ उसी के नीचे हाँ नहीं that is ये नहीं आया webcam है and that is share your screen but it is cross it's not like हाँ okay share yeah okay share after I've clicked on share screen then what do I do
विंडोज सिलेक्ट विंडोज
select windows will entire screen है windows हाँ okay then
सिलेक्ट योर प्रेजेंटेशन
Okay, presentation is the PPT में. ये नहीं है. दूसरा वाले मॉड्यूल. ये बंद कर दो. नहीं है. ये नहीं है. Next one. Okay, is it visible? Yes.
No.
Share. Share. Send link. इसमें send link आया है.
Send link.
Share block है ना. ये है. Share. ये भी नहीं आया. ये blocked है. अच्छा, वो blocked है actually. I'm not able to share.
मैम आप एनीडेक्स वगैरह यूज करते हैं?
नहीं, I generally use Zoom और LMS ना.
नहीं, एनीडेक्स वो जो है रिमोट डेस्कटॉप यूज करने के लिए.
Permission to access screen wasn't granted आ रहा है.
Madam, our
मैडम
screen shows
आपका
your
कैमरा
login.
जो है, आपका पहले कैमरा शुरू करिए.
कैमरा मेरा कोई ऑन नहीं हो रहा है. वेबकैम.
Madam, you will have to start the webcam.
वेबकैम ये ऑन करके देखें. ऑन नहीं हो रहा है.
उनके कनेक्शन
हाँ, सरफेस कैमरा फ्रंट ना. स्टार्ट शेयरिंग. ब्लॉक ही आ रहा है. इट इज नॉट.
Madam, can you just take the technical support at your side?
No, that's why my husband is helping me.
Yeah, okay. You are at distance.
Send the link again. I'll again rejoin.
Just send the link again, please.
Mail it if possible, because हाँ. So I'm Dr.
Let me introduce you to our new PGs. You need no introduction, but for the newcomers, I think they should know about you. So give me 2 minutes. Dr. Akanksha will introduce you.
Okay. Okay.
A very good afternoon, everyone. I, Dr. Akanksha Kumar, on behalf of Department of Orthodontics, feel extremely blessed to invite our esteemed guest speaker for the next session, one of the senior most and illustrious member of the orthodontic fraternity, a person who needs no introduction, my mentor and inspiration, Honorable Dr. Sunita Shrivastav ma'am. Rightly called as the teacher of the teachers, ma'am is an epitome of exceptional education and clinical experience who has held multiple roles as a dynamic clinician, passionate academician, and as an able administrator. An alumnus of the prestigious Government Dental College, Nagpur, with total experience spanning to about 3 decades, ma'am has served as a PG and PhD guide and has a keen scientific interest and expertise in many orthodontic techniques, including growth modulation therapy, biomechanics, temporomandibular joint disorders, cleft and pre-surgical orthodontics. With multiple publications, copyrights, and patents to her credit, she has been invited as a speaker at various national and international platforms and has mentored numerous orthodontists from all over the country. She is also the recipient of several prestigious awards, including the Best Research Award in 2016 Indian Orthodontic Conference and the coveted Professor Indira Parekh 50 Women Education Leaders Award in 2019. She is currently serving as the Dean Examination and Convenor of PhD Cell, Dattamege Institute of Medical Sciences, Dean University, Savangi, and is also a permanent member of Biomedical Engineering Board, VNIT Nagpur. With unmatched zeal and devotion for the subject, she is a mentor par excellence who has been the transformational force in the lives of her many students, including me. Ma'am, we are truly privileged to have you with us and get this opportunity to learn and master our basics from an expert like you. With heartfelt gratitude, I now request respected Dr. Sunita Srivastav ma'am to commence her scientific session on mechanism of action of myofunctional appliances. Ma'am,
Thanks
we
a
can
lot.
start.
Yeah, thanks a lot, Akansha. As is your privilege, but it's my privilege also to have students like you. And a teacher is a teacher because of students. And I hope the PG students which you now have also prove the same. So I'm Dr. Sunita Shrivastav. I'm at present I have left the job of Dean Examination. I'm Director PhD Cell, solely working for PhD, and also I'm the Professor of Department of Orthodontics. Akansha, next slide, please. Akansha, next slide, please. So these are the content on which I will be speaking about. Actually, it is a very vast and interesting, and I usually like to teach this mode of action with on a chalk and board because it's very easy to explain the mechanism with the help of drawing diagrams and all. Let's see if I'm able to do it the same way here. Uh, uh, Rashmi madam, I would like to ask your technical expert if I want to use my pen, can I use it? Can I, because in other way we have a logo of pen. So can I use the pen? If want to use, I want to demonstrate or point out something. Can I use a pen? I can share the
Uh,
screen share.
Ma- Yes, ma'am. I guess, ma'am, it will be difficult because we are sharing the scene from our side. So
Okay.
you won't be able to use your pen.
Okay. So let's see if I'm able to,
We'll
because
just
most of the
reshare the presentation now.
yes, yes, yes. Next slide, please. One minute. ये रेबत का सर, मैं वेबिनार में हूँ, प्लीज थोड़ी देर बाद बात करिए ना, प्लीज। मैं इम्पोर्टेंट, मैं 1 घंटा में बिजी हूँ, प्लीज थोड़ी देर बाद बात करिए ना। मेरा वहाँ पे हाँ चलिए प्लीज शेयर स्क्रीन आकांक्षा नेक्स्ट स्लाइड
Yes, ma'am. Just a minute.
Madam, you can start.
Ma'am, we have shared the screen.
Yeah. So basically we all know and हम लोग ने literally हमारे UG and PG के अंदर में we have literally ratified and marked it up that what are functional appliances. So in a nutshell, functional appliances are those appliances which are were usually the passive myofunctional appliance especially, which would harness the muscle force and then it would transmit or eliminate the desired and undesired force and accordingly bring about changes or in the alteration in the position of the jaw. And the best way to demonstrate is basically we are referring to the forces that are exerted in the orofacial capsule, orofacial structure, which comprises of buccinator mechanism and the TM joint. So most of the appliances which are myofunctional appliances are altering these muscle relationships, the muscle disharmony, and also modifying the TM joint architecture. And again, we are trying to modify the growth, which is just a part or extension of the natural phenomena. Next slide, please. This is the basic mechanism by which I have shared a link because unless you understand the morphology of the TM joint and the morphology of architecture of the buccinator mechanism, you won't be understanding growth, nor you will be able to understand the mode of action of myofunctional appliance, nor you will be able to understand TMD because working in all the three together, I have learned that there is a strong interlink between them and unless I know my basic about the TMJ morphology or the buccinator mechanism, I will not be able to understand any two aspects: how the growth occurs, how the myofunctional appliance work, and what are the causes of TMD. So basic mechanism is of the functional appliances, they are altering the muscle function, identifying the abnormal muscle function, redirecting or correcting the muscle environment. Then we are creating this through the patient bite blocks, and by this in class 2 cases, we are achieving a forward posture of mandible, but myofunctional appliances are also applicable to pseudo class 3 cases also. So in class 3 cases, we are causing exact opposite, that is the retrognathing position of the mandible. So whatever is happening in class 2, exactly opposite is happening in class 3. We are again, there are three modes of methods by which mode of action, because there are multiple myofunctional appliances, all cannot be explained by one mechanism, so each have a different mode of mechanism of action, and I will try to explain them systematically in each quarter. So either as proposed by some, it is because of lateral pterygoid muscle activity; as proposed by some, it is because of the stretch of the viscoelasticity of the bilaminal zone; or as supposed by that, it is because of the light bulb analogy or the growth relativity theory. I'll be explaining all this in detail with the subsequent one. Next slide, please. Now, the basic contention, what we all know is basically we are taking the mandible in a forward position, which is altering the morphology or architecture in the TM joint, the hard tissue and soft tissue relationship, which is bringing about the growth of condylar level. It is also causing remodeling of the glenoid fossa. So, in a nutshell, this is the mechanism in brief how a myofunctional appliance in class 2 cases is bringing about the changes. Reverse changes are seen in class 3 cases where, if you remember your biology of tooth movement, whenever you are exerting force, there's a zone of pressure created and a zone of tension created. A zone of pressure where there's a compression of the periodontal fibers, and at the zone of pressure, there's a stretch or tension, there's a stretch of fiber. And we all know that wherever there was a compression, there was a bone resorption. Wherever there was a stretch, there was a bone deposition. Now, the same philosophy is applied here. You just have to translate it in the glenoid fossa condylar morphology. So, when we are bringing the mandible forward in class 2 cases, we are reducing the anterior joint space, increasing the posterior joint space. So, we are creating a zone of pressure on the anterior side where compression activities occur. So, there will be resorption. And the posterior region, we are creating a zone of tension or a stretch, which is going to cause bone resorption. In class 3 case, we are doing the reverse. That is, when we are pushing the mandible behind, we are reducing the posterior joint space, increasing the anterior joint space. So compression at posterior will cause resorption. Tension or pull, stretch at the anterior will cause deposition. Most of the time we are just reflecting on class 2. I will also like you to reflect simultaneously on class 3. Then you will be able to logically understand the mechanism of action. Next slide, please. Now, the basic mechanism of action not only occurs by alteration in the jaw mandible advancement or mandible retrusion, but also there is a changes which are occurring in the functional cranial component of orofacial component. Now, the uniqueness of orofacial matrix is that it has got both the component of capsular matrix as well as the periosteal matrix. The capsular matrix, where the growth of the hard tissue is translatory and secondary to the growth of the soft tissue, which does not have any attachment to the hard tissue. Tongue does not have any attachment to the bone structure. Therefore, the growth of the tongue is just exerting forces on the surrounding hard tissue, and translatory growth of the surrounding hard tissue occur, evidence of which we know that the tongue size is large, the jaw size is wider. If the tongue size is small, the jaw size is narrower. So this is the capsular aspect of the orofacial matrix. And the periosteal matrix is due to the mucoperiosteal junction. Any stretch created in the mucoperiosteal junction is going to bound to create a bone deposition. And using this philosophy, we are again are trying to understand another mechanism of action of functional appliance. Next slide, please. Am I clear till now? So when you want to understand the mode of action of functional appliance along with the mode of how the growth occurs, you have to know two basic theory very thoroughly. The first was, as I said earlier, was the functional matrix theory. And the second theory, which you should know, is the servo system theory or cybernetic theory, as was proposed by Petrovic. Now, in brief, it's a very elaborate theory, and if you sit and go for each, you will understand it better. So, but we know one thing is that the cranial growth will control the maxillary growth, and because of the cephalocaudal growth gradient, the maxillary growth occurs earlier than the mandibular growth. Now, what happens is, according to this, the maxillary growth is the controlling element and the mandibular growth is a controlled element. So what happens is, when the translation of maxilla and due to inherent growth of maxilla, the maxillary dental arch is carried forward, the occlusal inclined plane of maxillary arch are taken forward or more anteriorly. So there is a lack of harmony in intercuspation. This sends a proprioceptive signal to the CNS, and the CNS will send a response signal, reactionary signal to the protractor muscles of the mandible, which will take the mandible forward. Now, this is a normal natural growth process which occur, the increment of which may be just 0.1 millimeter. In absence of this natural phenomena, we are trying to create an artificial phenomena in the same pattern. So unless you have understood the cybernetic model, the role of maxillary dental arch occlusal inclined plane on the growth and development of the mandible and how the prematurity of maxilla affect the growth of the mandible, you will not be able to understand the mode of action of functional appliance. What is naturally done, as explained by servo system theory, that we are trying to create artificially or mechanically by the use of functional appliance. Next slide, please. Am I clear about this theory? Because this is going to come into picture later on. So am I clear about this theory?
Yes, ma'am.
Okay. Now, basically, why we are orthodontic came into picture and why this mode of action of functional appliance came into picture is because of the mechanical forces which elicits a response on a bone. So because there are multiple soft tissue forces which exert force on the bone, and unless you understand the biomechanics of development or bone growth or bone remodeling, again we will be like in the first phase of functional matrix theory, and we will still have not revisited what makes your functional matrix work, what the periosteal matrix work. So unless you understand the mechanism by which the muscle contraction or stretch occurs, and how does it exert force on the bone, and how does a bone response to that given force, you will not be able to understand the mechanism of action of myofunctional appliance. So basically we are understanding the biomechanics of our muscles and heart tissue or the stomatognathing system. Next slide, please. Now, basically, the primary forces are the forces which are generated by the natural muscle function. When you're solving, we have all learned the passive muscle force, the active muscle force, how they alter the tooth position, and what happens if there's a disharmony in the soft tissue, and what will happen to your hard tissue. So the primary forces are generally created by natural muscle force. We are creating a secondary muscle force which is due to the altered muscle function. So next slide, please. Sorry, I think the slide is missed. So secondary muscle forces are generated when you are activating those muscle by your mandible propulsion appliances or your mandibular advancement appliances or mandibular retusion appliances. So either there will be force. Basically, we all have learned the philosophy of how the myofunctional appliance work is. It works on the principle of force application and force elimination. So next slide, please. So wherever we desire in your buccinator, if you remember or recollect your buccinator mechanism, there is a tongue which is surrounded by the dental arch, which is surrounded by the buccinator muscle posteriorly, laterally, as well as anteriorly the upper and lower lip muscle, the upper and lower lip muscles, orbicularis oris muscles. Now, when there is a balance between the forces exerted by the tongue and the forces exerted by the buccinator muscle, the position of the teeth will not be in harmony. If you remember, you are taught that the principle of orthodontic tooth movement or the is Newton's three law of motion. So basically, we also have to understand the Newton's second law of motion, which has two components. It is like when the body is in acceleration and somebody pushes, it will accelerate the speed. Or when the body is in motion and then opposite force is exerted, it will retard its motion. So that the first one is known as law of acceleration, and the second one is known as law of equilibration. The teeth are not in a position of rest. They are in a position of equilibrium. They are basically balanced by the forces exerted by the tongue and the forces counteracted by the buccinator muscle. So we know that when the tongue is retro position, the forces exerted by the tongue reduces. So the buccinator force, the imbalance created will cause constriction of the arch. We know that this mechanics, we know and understand it. Or if the tongue is anteriorly positioned or large in size, the forces exerted by the tongue becomes larger and the forces exerted by the buccinator muscle cannot counteract it. So it causes expansion. So basically what is happening there is wherever it is desired, you allow the muscle force to exert, or you stimulate the muscle to exert force in a desired direction. Wherever you don't desire it, you eliminate or block the force. Next slide, please. So basically, whatever is the restrictive forces of the environment, example of which is vestibular screen or the buccal shields of Frankel appliance. When the tongue position is retro, we want to bring the tongue forward and allow the forces to be exerted by the tongue on the dental arches so that it will widen. And to allow it to widen, we eliminate the buccinator muscle force. So this philosophy of force elimination and force transmitted is well explained by your functional matrix theory also. So this concept was utilized by the Frankel for Frankel regulators. Next slide, please. Now, during the elimination of force, basically a stretch force or tensile force is there, which will cause stretch in the mucoperiosteal junction, which is going to stimulate the bone formation. And wherever they were exerting a tension, it is comparatively more effective than the pressure. So wherever you are planning of your myofunctional appliance should be such that you have planned zone of tension and you have planned zone of pressure. So in the area of pressure, you're allowing force to be exerted on the heart tissue structure, and in the area of tension, wherever undesired, you're eliminating the forces from that structure. So this is how you're allowing a myofunctional appliance to work. Next, please. So apart from dental movement, during the developing age, you are also allowing jaw growth. So once the dentition come into picture, the forces which are acting on dentition bring about changes in the dental arch. But the same principle is also exerted on the hard tissue, that is the maxilla, mandible, and along with the teeth. So there are multiple theories who have proposed by which you can explain the mode of action of functional appliance. Next slide, please. The first theory, as was proposed by Anderson and Hoppel, and later on it was elaborated and substantiated by McNamara and team, was the muscular hypothesis, in which they stated that because it is also known as muscular hypothesis, and this explained the mode of action of activator and its associated appliance. And they say that it is a muscular activity which influences the mandibular growth. Next slide, please. So it is the myotatic or the stretch reflex of especially the protractor muscle, specifically the lateral pterygoid muscle. Everybody in the beginning thought that it was the lateral pterygoid muscle which played a crucial role in the growth of the mandible. And this was a concept which was utilized or used for explaining their hypothesis by Anderson and later on McNamara and group. Next, please. So they have, from their studies, the hypothesis they have tried to substantiate by the work of McNamara, Petrovic, and Stutzman. They said that there is a direct correlation between condylar growth and lateral pterygoid muscle hyperactivity. There are multiple terms which they have associated with this pterygoid muscle, which will come across later on. Next slide, please. Now, how these muscles are activated, because if you remember, you have functional matrix theory and later on you had functional matrix theory revisited. So do you know which component of functional matrix theory was revisited? It was not the capsular component, because it's very easily explainable that as the size of the organ grows, the size of the surrounding heart tissue grows. But again, Enlow had asked Dr. Melvin Moss, okay, tell me, sir, that the soft tissue periosteal matrix pull brings about changes in the heart tissue. But what makes those soft tissue work? So with that came your functional matrix theory hypothesis, which was revisited, and then they explained the mechanism of mechano-perception, mechano-induction, and mechano-transduction, and therefore which causes bone formation. So how does these muscle are activated? So I have explained to you before also, as per the cybernetic, next slide, cybernetic theory of Petrovic, or the servo system theory of Petrovic. When you bring your mandible forward by the activity of your, what was being done, there was a disparity created by faster growing maxillary dental arch occlusal inclined plane, which sent a signal through proprioceptive receptor to the CNS, and then the CNS brought the mandible forward by stimulating or sending signal or command to the protractor muscle. In our myofunctional appliance, we are doing what the CNS was giving the signal. We are bringing the mandible forward and stimulating the protractor muscle. What the CNS activity was doing, we are doing through our construction bite and through our appliance. So are you understanding? So we are creating an input which was missing in the patient's mouth. So unless you understand what was lacking, you cannot be able to put the input, right input, and we are sending the right signal which is going to stimulate the bone deposition. What was happening in the increment of 0.1 millimeter, we are trying to achieve it in the increment of 5 millimeters or more. Next slide, please. So again, I said it is the upper dental arch which sends the command, or which sends the causes the response, or which is the reason why the response occur. And basically, this will cause a deviated signal, and this deviated signal will evoke a motor response of the protractor muscle, and this will automatically will try to reduce the protraction activity and exert the desired force as it is not allowed to go back. Next slide, please. So basically, it applies that it is a supplementary contractile activity. What was being done as a command, we are creating a command and then generating a response. Are you understanding? We are not waiting for the CNS to give a command. We are developing an artificial command and giving it, and we are bringing about the changes which was naturally occurring by the artificial mean. And by stimulating the protractor muscle, we are stimulating the growth of the condylar cartilage, which will consequently cause lengthening of the mandible. I would have liked to use my pen here, but I'm not able to, because I would have been able to explain with diagram more better. Next slide, please. Have you understood this? Have you understood this aspect? So the proponent of this theory, they have substantiated this theory by 4 experiments. In the first experiment, what they did was they surgically resected the lateral pterygoid muscle in a growing rat, and they saw which were treated and not treated by the functional appliance, and they found that there was relatively decrease in the condylar cartilage growth. So this was directly linking the growth of the condylar cartilage or condyle growth or mandible to the lateral pterygoid muscle activity. Next slide, please. The second experiment was directly you are checking the electromyographic record of lateral pterygoid muscle in monkey who were treated with myofunctional appliance and those who were not treated with myofunctional appliance, and they found that there was increased electrical activity in the lateral pterygoid muscle in those treated with functional appliance. So again, they substantiated that somewhere there's a role of lateral pterygoid muscle in bringing about changes in the condyle and mandibular growth, which we are trying to initiate by a myofunctional appliance. In the third experiment, what they did was they directly stimulated the lateral pterygoid muscle by intermittent electric shock, which was 5 times per second for 10 minutes with a potential of 0.55 voltage. Next slide, please. With this, what they observed was that this micro stimulation, electronic stimulation, was causing increased rate of activity in the condylar cartilage growth. So they again said that there is a direct correlation between the stimulation of lateral pterygoid muscle with the condylar cartilage growth. So again, they said this was a concept which was proposed initially by Anderson and Hoppel, and they have stated very well that the anterior advancement of the mandible should be done, but the bite opening should be kept within the physiologic. You have 3 concepts of consuction bite. Now, to understand this, you have to understand why that theory was proposed. So, whoever has advocated that the anterior advancement of the mandible should be there, they have also advocated that it should be within the physiologic freeway space. Otherwise, if you are increasing the vertical bite, it is going to cause a clasp knife-like reflex, which is a pathological condition, and therefore you may not elicit a response. And the fourth experiment was that after the treatment with postural hyperproposal, they found that, you know what we do, what is the role of myofunctional appliance apart from bringing out changes in the skeletal basis, it also causes lengthening of the muscle. Now, this lengthening of muscle is not because the length of each sarcomere increases. It is because the length of the sarcomere remains same. It is the number of sarcomere which increases. So lengthening of muscle occurs because there's increase in the number of sarcomere and therefore the muscle fibers. So again, by the fourth experiment, it was proven that by the use of myofunctional appliance, there was increase in the length of the lateral pterygoid muscle, but there was increase in the number of fibers, which was due to the increase in the number of non-fatigable fibers. Next slide, please. Am I clear about this, everybody?
Yes, ma'am.
So they have suggested that there's a direct linkage between the lateral pterygoid muscle activity and which causes a tension in the posterior part or the retrodiscal part of the condylar capsule because of through its attachment to the articular disc. Now again, I told you that I would at the end of the seminar I have included two links, two videos. One video is indicating the Tnj morphology. It is a dynamic video where you can understand how it works. It is not only the articular disc, how the lateral pterygoid muscle take part in bringing about the movement of the lateral articular disc. See, lateral pterygoid muscle at its origin is on the lateral aspect of lateral pterygoid plate, but at its insertion, it is divided into the superior and inferior head. The superior head is continuous with the articular disc and controls the activity of the floating articular disc, and the inferior head is connected to the condyle. So unless there is a synchronized movement or function of the superior head of lateral pterygoid muscle and inferior head of lateral pterygoid muscle, there won't be a synchronous movement of the articular disc or the condyle. And this is one of the basic reason. And when you pull the articular disc forward, in the retrodiscal area, the articular disc again divides into two lamina. So it is such a beautiful natural architecture that the articular disc connects to the cranial base in the glenoid fossa by menisco-temporal ligament and connects to the mandible or connects the mandible. It's a mandible is just a floating bone. No? It is connected through the soft tissue to the cranium and maxilla. Clear? To the cranium basically. So the menisco mandibular ligament connects the mandible condyle and the posterior aspect of condyle, and together when the articular disc is pulled forward, it is this two ligament that are stretched forward, and in this area because of this stretch the bone deposition or bone remodeling in the condylar or the condylar growth occurs. Am I clear with this? So they said it was the lateral pterygoid muscle which brought about the articular disc forward positioning along with the condyle, which caused the stretch in the retrodiscal area, which brought about the growth in the condylar cartilage. Am I clear? Next slide, please. Now, you may have heard, the second years may have heard, or the third years may have heard when the seniors were giving exam, the examiner asked you what is a pterygoid response. Now, do you understand? Everybody had linked pterygoid muscle, lateral pterygoid muscle to the mandibular growth, and therefore, whatever terms were there were related to them. So, what they said that when the mandible is brought forward, the along with the inferior synchronous movement of superior and inferior head, the articular disc was pulled forward, which caused a stretch of your bilaminar zone in the retrodiscal region, which caused anterior में क्या हुआ? There is a reduction in the anterior joint space. So what will happen there? Bone resorption. In the posterior segment, what happened? There was a stretch created. What will happen there? There will be a bone deposition. So within 45 days of delivering your myofunctional appliance, basically, if there is a favorable hormonal activity, you have targeted the child in the right period of growth, what will happen? This remodeling of the glenoid fossa condylar relationship will occur. So anteriorly, there will be resorption of glenoid fossa. Posteriorly, there will be deposition in the glenoid fossa. Next slide. Let's me see if there's a diagram there. No. Okay. Next slide. If there's a diagram. Okay. No. Go back only. Go back. So what will happen is, what in response to the tension, there will be bone resorption in pressure in the anterior region, resorption, posterior region, bone deposition. So what will happen? Your joint morphology will be restored back to the earlier dimension. So there won't be any space. The increased joint space has reduced because of bone deposition. So when you try to take your mandible behind, there's an interposed soft tissue, the articular disc. Will you be able to take your mandible behind? The joint space has reduced because of bone deposition, and when you try to take your condyle behind, mandible behind, it is not going to be allowed because of the bone deposition which has occurred there, and you will be compressing the articular disc between, and therefore patient will elicit pain or patient will not be able to take the mandible behind. This is what in a nutshell is a pterygoid response. If in an adult this response does not occur, the resorption will occur, but bone deposition does not occur. So what happened? The glenoid fossa joint cavity has increased. So the patient can take the mandible forward also, patient can take the mandible behind also. So that is why you have a dual bite, you have a phantom bite, you have a ghost bite, you have a Sunday bite. Are you understanding? Only when there is an active phase of growth, only when the condylar cartilage are responsive, then only a pterygoid response will elicit. And if you have targeted the patient in the right time, you will be able to elicit a pterygoid response. If it is in the adult age, you may not elicit a pterygoid response. But this term was basically linked to the activity or muscular activity of lateral pterygoid muscle, which brings about growth of the condyle or in growth of the mandible. Is it clear? Next slide, please. Now, here, the remodeling basically occurs due to growth occurring in the condylar cartilage, which is increasing the length of the mandible, as well as due to the remodeling. आपका anteriorly resorption हुआ, glenoid fossa में और posteriorly deposition हुआ. तो आपका relocation of glenoid fossa हुआ. So basically by these two mechanisms, either by deposition of bone in the condylar cartilage region and the glenoid fossa, and resorption of bone in the anterior surface of condyle and anterior surface of glenoid fossa, you are relocating the glenoid fossa. So by these two mechanisms, the growth of condyle occurs or growth of mandible occurs in response to your myofunctional appliance. Is it clear?
Yes,
So
ma'am.
this completes the first philosophy by which the mode of action of myofunctional appliance occur. This can be very well explained by the H activators and myonators and all the horizontal types of myofunctional appliance. Next, please. Now this here we are saying that because the mandible is brought forward, there is a stretch created, and therefore a response occur in the form of condylar growth. But what happens in V activator, where minimal advancement is done, maximum vertical opening is done. So again, whatever was the philosophy placed forward by Anderson and Oppel, and later on again propagated by McNamara and Stutzman and group, it was again negated by the work done by Johnston in 1970. They said it is not the lateral pterygoid muscle activity, but the viscoelasticity of the articular disc and especially the bilaminar zone. Next, please. So they said the tissue is viscoelasticity. So by altering its viscosity, you're changing the dynamics, the biochemical, biomechanical, bioelectrical dynamics of the TN joint, and this creates a bioelastic process which causes bone deposition. What McNamara and had proposed that the lateral pterygoid comes forward, therefore pulls the lateral bilaminar zone, and therefore creates the bone deposition. But this does not explain when the mandible is not brought forward. So when the mandible is brought downward, there is going to be a stretch created irrespective whether the mandible is brought forward. The mandible is basically displaced. Next slide, please. So to explain in condition where the first theory cannot be explained, this viscous elastic theory tries to explain. And they have stated that it's a non-muscular philosophy. They stated there is no role of lateral pterygoid muscle. And it is basically, next slide, please. Basically, it is a stretch created in the retrodiscal pad in the bilaminar zone, which is going to cause in the responsive condylar cartilage, the bone deposition, and the responsive glenoid fossa, the remodeling. In anterior region, there will be resorption. So it is not the lateral pterygoid muscle, because lateral pterygoid muscle is just doing its function in pulling the articular disc and thereby pulling the bilaminar zone or the retrodiscal tissues. But it is the retrodiscal tissues which is exerting force directly and directly bringing about the growth of the condyle and glenoid fossa. Next slide, please. Is it clear, everybody? Now, irrespective whether mandible is brought forward actively or passively, the growth in the condylar region is going to occur if you are initiating a stretch in the retrodiscal region. So this basically forms the mode of action of bite jumping philosophy. And this also in your Hertz appliance and other appliances. This explains how the mode of action of functional appliance occur, how the response in the growth of mandible occurs. Next slide, please. Now, the third hypothesis was placed by functional matrix, where they have said, already said, next slide, because I've explained part of it. So we all know that either indirectly in the capsular matrix or directly through periosteal matrix, the soft tissue function is bringing about the changes in the hard tissue. So forces which are created in the muscle, which are transmitted through the neuromuscular junction through a command, the stress through the musculoskeletal junction in the bone, musculoperiosteal junction in the bone, are going about to exert force on the bone, and because of the plastic nature of the bone is going to respond. If it is compressive force, it is going to bring about appropriate resorption. If it is a stretch force, it is going to bring about your bone deposition. So they have stated that wherever there was, if you remember, class 2 division 1 has constricted maxillary arch, which does not allow the mandible to come forward. So this, it states that the mandible, because it's not brought forward or downward, there is no stretch in the posterior region, and basically because of this deficiency of this component in the mucoperiosteal junction and the desired pull, we are not able to achieve the desired shape, therefore desired response. So in order to create the first of all, you have to identify whether the mandibular deficiency is genetic in nature or whether is due to the altered muscular harmony in nature. So by bringing about that, identifying the wrong functional matrix forces generated, identifying what response it has created, and then giving the appropriate functional forces, the right functional forces, we are able to recreate an environment which is conducive to the normal growth. If the growth of mandible is deficient because of functional restriction, you will allow the growth. If it is genetically small mandible, if all these mechanism is not going to create any response. So one thing it should be clear, only when the mandible is functionally short or functionally retrusive, you are able to elicit a response. And this is explained by the functional matrix theory. So next, please. Huh. So, Frankel had advocated his appliances, also known as oral gymnastic appliances. So, he had identified the abnormal muscle function, abnormal buccinator mechanism, and its role on the dental arch shape and position. And based on that, he had created the artificial functional matrix with correct muscular environment or soft tissue environment, which will allow the growth of the mandible to occur. So, along with the functional appliance, he has also advocated stimulating all this muscle through exercise. And therefore, the Frankel appliance is also known as oral gymnastic appliance, because it is not only altering the position, it is also trying to correct the function of the muscle, which have been altered. The functions have been altered because of malocclusion or has been played a role in causing a malocclusion. Next slide, please. Now, again, it was this philosophy of Frankel of periosteal pull. See, whenever you are giving a buccal shield, you basically trim the model 5 millimeter more, so that your buccal shield stretches 5 millimeter above the vestibular height. So whenever you check, you also check whether the blanching is occurring or not. So basically what you are checking whether you are ensuring that there is a periostal pull. So you are basically utilizing the periostal matrix theory of functional matrix theory given by Melvin Moss. So you are identifying the fault, and whatever was the concept of growth explained by Melvin Moss, you are recreating that concept through your buccal shield, where you are eliminating the buccinator muscle activity, but you are transmitting the mucoperiosteal pull through your buccal shield, where it will ensure deposition of bone in the lateral aspect of the maxilla, where according to expanding V principle, there will be resorption on the palatal aspect of the maxilla, increasing the increasing the width of the maxilla, and this is known as passive expansion. Active expansion we do by opening the mid-palatine suture. Passive expansion is by stimulating the mucoperiosteal junction to deposit bone on the lateral aspect, with a subsequent remodeling on the palatal aspect, where there's a resorption, and therefore you are expanding the maxilla, and you're also changing the occlusal inclined plane relationship. So again, you're changing the command, and then you're sending the correct command through the mandibular arch occlusal inclined plane to the brain, and you're allowing the mandible to be kept in that position. Another thing which he had done was he had placed a lingual plate in the FR1B. You have a lingual plate. Now, do you know what is the role of the lingual plate? Just to anchor the appliance? No. The plate purpose of the plate is it's a reminder appliance. As soon as your mandible tries to go back, there is a impingement in the lingual aspect which reminds the muscle to place the mandible anteriorly. So here, are you using the principle of force transmission? Through your buccal shield, your principle of force elimination, and through the mucoperiosteal pull, again the principle of force elimination. So according to Frankel philosophy, the mode of action of functional appliance is by alteration in your orofacial matrix, or creating a new orofacial matrix which will exert the right type of force on the heart tissue and eliminate the harmful or undesired type of force on the heart tissue, thus normalizing the normal growth. Is it clear to you all?
Yes, ma'am.
Hello. Next slide, please. I would really love to take this along with, if I had with diagram, because it becomes more easy. If I use words, I miss out on diagram. If I use diagram, there are many things you may not be able to connect. So in short, the principle by which a functional regulator works, the mode of action of functional regulator is, there's an active muscular involvement through the proprioception. There's a viscoelastic hypothesis. There's a stretch in the tissue which are shielded by, there's a stretch in the anterior region through the lip pad, there's a stretch in the vestibular height through your buccal shield. So there's a stretch, as well as you're allowing the growth by eliminating the forces which are restricting the growth. So basically the three component is there. You're modifying the muscular involvement, you're modifying the viscoelasticity, and you're also screening the deleterious effect. Clear? So on this philosophy, the growth of the skeletal base and dentition occur through a function regulator proposed by Frankel. Next, please. Now, as was the functional matrix theory revisited, the viscoelastic hypothesis was also revisited. What did the viscoelastic hypothesis state? That it is the retrodiscal viscoelasticity of the retrodiscal tissues, which, when stretched, elicits a response. So this was again revisited by Woodoris and Kufnitek, and they proposed their growth relativity theory, which explains the mode of action of the all fixed functional appliance and many of the appliance. Next slide, please. So what does they do? They say that the basic concept is there are various activity involved. And the first activity is displacement of the condyle. Whether the displacement is anteriorly or whether the displacement is vertically, which is going to actually cause relocation of the fossa, as I've explained before. Next slide, please. Now they said that it is the see there were article in between who have said that there is no role of lateral pterygoid muscle because there is no connection between lateral pterygoid muscle and articular disc. So when the dissected models was checked, they found that there was close association and there were certain decussating fibers of superior head of lateral pterygoid muscle which were actively altering the function of the articular disc. So somewhere the close association of the superior head of lateral pterygoid, inferior head of lateral pterygoid, inferior head of lateral pterygoid and the articular disc together, they bring about the pull and the pull in the retrodiscal region. But this does not explain the bone deposition which occurs apart from other area apart from the condylar cartilage. You can see bone deposition in the associated glenoid fossa where the force was not exerted. So it was not only the viscoelasticity of the retrodiscal pad, but because the mandibular condyle is brought forward or displaced, there was activity change in activity of all the other non-muscular component. The TM joint, that's why I want you to please view the joint video, because there are various temporomandibular joint ligament, capsular ligament, all the other tissues are also associated with the Tnj morphology. It is not only that the lateral pterygoid muscle, articular disc, and the bilaminar zone. They are also surrounded by the capsular matrix, the temporomandibular joint matrix. When you bring the mandible forward, these viscoelastic tissues are also stretched. So this explains that not only the retrodiscal pad, but all the associated non-muscular soft tissues are also bringing about bone deposition in the glenoid fossa condylar region. Am I clear about this? So viscoelasticity is just upgraded version. It is not only the retrodiscal pad, but all the other capsular matrix, TMJ ligament, other soft tissue associated with the TM joint, which is bringing about the bone remodeling in the structures away from the condyle. Next slide, please. Am I clear about this?
Yes, ma'am.
Basically, according to this theory, according to the growth relativity theory by Woodhouse, there are three components involved. There is a displacement of the condyle, and there is a viscoelasticity, and which is going to cause the referred structure which are there, surrounding structure, the forces generated in the surrounding structure, which causes the changes or remodeling in the condyle and glenoid fossa and bring about changes in the mandible dimension and position. Next slide, please. So first, now go back. The first thing which occur is displacement. As I said, it may be naturally occurring or you are artificially doing it with the help of your myofunctional appliance. Naturally, the displacement was in response to command sent by central nervous system. Artificially, by your construction bite and your appliance, you are taking the mandible forward. So you are basically displacing your condyle in glenoid fossa. Second, next slide. Next slide. Second, the condylar is affected viscoelasticity as was proposed earlier by Johnston, that it is a retrodiscal condylar fibrocartilage which responds to the stretch activity of the retrodiscal viscoelastic tissue which is anchored between glenoid fossa and the condyle. Clear? Third is it is not only the stretch in the retrodiscal pad, but it is also the changes in the tissue environment of the synovial fluid. Now, it's a very good vehicle which allows migration, induction of the appropriate cells. So, because of the alteration in biochemical, biomechanical dimension of the synovial fluid, that is the reason why the changes occur in the condylar cartilage. So, basically, by mechanotransduction, the forces are exerted on the cap of the condylar head, and that is the reason why the growth of bone growth occurs there. Is it clear? So it is not only the retrodiscal region, but all the surrounding structure associated with that, which is bringing about. Another thing, initially they said that it was a lateral pterygoid muscle which causes. Next slide. Lateral pterygoid muscle which bring about the changes. But according to the proponent of this theory, it is not only the lateral pterygoid muscle. When you're bringing the mandible forward, you're changing the orientation relation of the masseter muscle, medial pterygoid muscle, all the supramandibular group of muscle, as well as submandibular group of muscle, especially the anterior belly or digastric. So the stretch created by it's not a simple mechanism of hyperactivity of lateral pterygoid muscle, but the change in the muscular function of all the associated muscle, which is going to bring about stretch in the condylar glenoid fossa in the TM joint region, which is going to bring about the change. Now, according to this, they have given the light bulb analogy. Everybody has seen a switch. अब जब आप लाइट बल्ब का स्विच ऑन एंड ऑफ करते, याद है पहले एक वो रॉड के जैसा आता था जिसको आप ऊपर नीचे करते थे, ठीक है? अगर आप हाफ वे रॉड को नीचे ले जाओ, आपका लाइट बल्ब एक्टिवेट होगा क्या? जब तक कि आप वो लाइट स्विच को पूरी तरह से नीचे नहीं करोगे, आपका लाइट बल्ब पूरी तरह से ब्राइटन लाइटन अप नहीं होगा. हाफ वे लोगे तो डिमर रहेगा. तो उनका दिस थ्योरी का प्रोपोनेंट ये है कि when you bring your mandible forward, there is a favorable activity of anterior belly of digastric, favorable activity of lateral pterygoid muscle, activity which is occurring in the retrodiscal pad, activity which is occurring in the surrounding referred structure of the TM joint, and only when all these are adequate, then only the light bulb will be switched on, then only the bone growth will occur. With when you give a myofunctional appliance, the mandible come forward. So what happened? The stretch become lesser. So what happened? आपका switch halfway चला गया. So this is the reason why there is a dimmering of the light bulb with the anterior development of mandible. And that you have to check from time to time so that you ensure that your light bulb remains active throughout. Have you understood? So it is not one thing which is explaining the growth of mandible. There are multiple components which are occurring together, which is bringing about the change in the mandibular growth via myofunctional. Next, please. Again, this was explained by their theory that it is not only the superior and inferior head, which is in red here, of the lateral pterygoid muscle, the stretch created in the retrodiscal pad and the surrounding structure, which is bringing about growth in the cap of the condyle. Am I clear? Next slide, please.
Yes, ma'am.
Next slide. So after considering all these hypotheses, they no, please previous slide. Which do you think is the best way of explaining mandibular growth? So next slide. Let me tell you, it was again proposed that there is no single. Next slide. There is no single forces. It is not only the regional functional forces, but also the associated functional forces and extra condylar activating signal, which brings about the growth. Next slide, please. So basically, no single theory. Mandibular growth can be explained by no single theory. Basically, all the theory together will be able to explain the mode of action of myofunctional appliance in bringing about the growth in the mandible. Next slide, please. No, I have explained this, no? No. I think with this, I've taken adequate of your time. If I try to go more, it will logical thinking will be there. I hope you are able to understand. Will you be able to understand mode of action? These are the changes which occur. Mode of action का तो मैंने mechanism बताया. What are the changes that may occur in due course after the use of my functional appliance, which you have to record. So with this, I come to the end of my webinar on mode of action of myofunctional appliance. I would really love to teach you with help of your on the physical mode. So I've shown my acceptance to Dr. Rashmi Zavdekar. So anybody has any question, or tomorrow if you are asked questions, will you be able to answer? Have you understood how the mechanism of action of condylar growth occurs?
Yes, ma'am. It is
Anyone,
understood.
any questions? Any questions? Any doubts you want to get it clear? Please fill in YouTube.
If there's no question, Rashmi madam, I'm really thankful for giving me an opportunity to address to one of the area which I really love. So I
Thank you,
hope
madam, for wonderful presentation. Students, if you have any doubt, you can just ask her.
you have Dr. Rashmi Zavdekar as a person. Through her, you can approach me, or you have Akansha also. But Rashmi was my teacher also, and one of my role models when I was doing my undergraduate, and one of the reason why I joined orthodontics. So,
Thank you so much.
so please may
I now
I?
request Dr. Pankaj to give vote of thanks. Thank you, madam, from the base of my heart for a wonderful explanation. And it's almost a textbook you have explained in such a short time. So, if they read it, I think they would have taken a month to read all the simplified things you told in a very nice way. Thank you once again for sharing your time. Though you are so busy. Thank you so much. I request Dr.
Thanks a lot.
Pankaj Akre to give the vote of thanks.
Good afternoon, one and all. I, Dr. Pankaj, Professor, on behalf of the entire department, would like to extend my heartfelt gratitude to our esteemed speakers for today, Dr. Gauri Vichare ma'am, Dr. Toshniwal sir, and Dr. Sunita Shrivastav ma'am, for sparing their valuable time and sharing their expertise with us. Thank you so much, each and everyone. Thank you so much, madam and sir. It is a pleasure to thank our Honorable President, sir, Shri Sharadji Karmik, sir, our Honorable Secretary, sir, Shri Hemantji Karmik, sir, and Management Committee for giving us this wonderful opportunity to conduct this webinar. I would also like to thank our respected Dean, sir, Dr. P. Mahesh, sir, for his constant support and guidance. I would also like to thank Dr. Rashmi Zavdekar, ma'am, HOD, Department of Orthodontics, and the entire organizing team, Dr. Harish, sir, Dr. Akansha, Dr. Nivedita, Dr. Sneha, Dr. Komal, without whom this session would not have been possible. I would also like to thank our technical team, Ashish and Arif, involved in this successful webinar. Last but not the least, I would like to thank all the participants for the patient listening. Thank you so much, everyone.
Thank you all.
Thank
May
you,
I
ma'am.
leave? May I leave?
Thank you everyone for being here and patiently listening. And also sorry for the connectivity issues, which did take a bit of more time. Any doubts, ask Dr. Toshniwal, Dr. Gauri Vichare, and Dr. Sunita Shrivastav have explained. Any doubts today or even later, you can contact them through directly or through any of the staff in the department. Thank you so much once again, and with the hope of meeting factually, or if not factually, a better organized and better connectivity webinar